Very likely to run out of time, and I'm sure that everybody's eager to hear what Martina has to say. So we're going to kick off straight away. Hello, and a very warm welcome to this NOI Group clinical discussion. My name is Joanna Taylor, and I am Director of NOI Group Europe. I'm joined today by NOI teacher Martina Egan Moog. I don't know how to pronounce your name. Can you pronounce that for me so I can get that right?
Moog.
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 Yeah, okay, good.
You've got the Egan part, right? Egan Moog.
Thank you. I'm sure you hear lots of variations.
That's fine.
Martina is a pain physiotherapist with over 20 years of experience bridging pain science research and clinical practice, teaching in both English and German across Europe and Australia. Martina, could you start by telling us a little bit about what you are doing professionally at the moment?
So I'm in the clinics. I'm working 5 days in the clinics, but I'm wearing two different hats. On 2 days per week, I'm working for an interdisciplinary outpatient pain management program. So hand in hand with a psychologist on the ground, with the support from the doctors around it. So this has been, I've been involved with interdisciplinary pain management since over 20 years. And this is actually my my two relaxing days in the week. So, because I feel like we're there as a team. We see very complex clients, mainly work cover, so work accident, work-related injury, or traffic injuries. So a third-party insurer. But I feel like I've got a team behind me. And the other 3 days I'm working in private practice with the idea of looking after these clients by myself. And this is when I feel like that's when it gets interesting and sometimes really challenging, because you're holding a lot of space for these people and they come to you as a physio, but there's obviously a lot of other psychosocial factors to address at the same time, and yet I only have a half an hour physio appointment. So this is where I find I have to be on my toes. And yeah, so during those days, so I've got a lot of agency and can be quite creative what I'm doing. So I've worked in a out of a yoga space and out of a boxing. So I'm 1 day a week. I was in a yoga for many years in a yoga studio and had saw my clients in a yoga studio, and then I added the boxing gym. And then, so I've only since the beginning of this year decided this is getting very complex. So I brought it all into the boxing gym.
Brilliant.
And so that's actually an interesting experience because some of my clients, they come in and they see the boys boxing or the girls boxing. And it sets a tone. That doesn't mean I throw them into the boxing ring, but close to as possible. So it's an interesting experience, an interesting environment to try to get some movement-based therapy happening. Yeah, so this is sort of my clinical environment at the moment.
Fantastic. So interesting that you're bridging two very, very different working environments, and that will only enable you to understand the different environments that people who come on your courses are working within. So that's fascinating. And I hope we get the opportunity to hear more about the movement-based within the boxing gym at some point, because that sounds really interesting. That's great. Thank you, Martina. Wonderful. So these sessions are all about giving you a taste of explain pain and how to practically use it in your clinic. Some of you on the call will have already done an explain pain course, and for those of you who have, these sessions are designed to reinforce and extend what you have already learned. But if you are new to explain pain or new to the NOI methodology, this is a wonderful place to start, and it's very fitting given what we're going to be talking about today. So Martina has some courses coming up, both online and in person in German, and we're going to tell you a little bit more about those at the end of this session. So if you're interested in diving deeper with Martina and understanding the courses that she presents, then please do hang around and we'll give you some more information. So just a couple of things before we get going. Martina and I are going to be talking for about 20 minutes. If you have any questions, please pop them in the Q&A or the chat, and we will get to as many of them as we can. I'd encourage you to leave them early because we always run out of time. So, and if you want to watch the recording of this, it will be uploaded to our YouTube channel following the end of the session, and I will drop the link for that into the chat. Please do come and subscribe to that channel, because there are loads of these sessions on lots of different subjects and they are superb. So let's get started. Let's start at the beginning, because I think a lot of clinicians who are joining us today are somewhere on the journey of realizing that what they were taught about pain might not be the whole story. Pain is something that we encounter every day in clinical practice, and yet many of us feel like we are never really given the tools to understand it properly. So why is that, and why does it matter so much?
Well, in the bigger scheme of medicine, pain science is really still in its infant years. I mean, we say the modern pain science really started with 1965 as a gait control. This is 60 years down the track. If you think about how long maybe the two of us are already in that field, it just does not feel that long. And during that time, we know from research that it takes about 17 years for science to land with clinicians in everyday practice. So it takes a while for new understanding to become common knowledge and change the way we look after and treat our patients. So I think there's this timeline, and it is a new research. And when I go back and I did my physio training in the late 80s, we did not hear much about pain. Even though our patients clearly had pain, but all we heard about was the action potential and the different fiber types. And so it is really, we have to honor that it is a very new field of medicine, and we need to be patient, both with our colleagues, other healthcare professionals, and because that is one of the problems, I think, what we see, even if we might be on top of our games in pain science. I work maybe with a team of healthcare practitioners who are not so deep down in that part of research science.
Yeah, that's fascinating, actually, because I think there is a huge pressure, isn't there, to for everybody to fully understand it, but it is still still relatively new. So it's really important doing these sessions where we do an introduction to things rather than always just going in at a very high level, because it just helps it helps people to feel welcome to this
and
understanding.
That is the problem for our explainpain course, is that the body of knowledge is growing, and we would like to introduce immediately the really exciting new things, but it doesn't make sense if we don't work our way from the bottom up. And 100%. It is a constant juggle. What are the standard fundamentals can you not leave out, and what do you also want to share in terms of the more exciting new topics? It's a constant juggle. But even just to give you an example, I mean, central sensitization is now a fundamental understanding of pain science. Central sensitization became known and more common knowledge in the mid to late 90s. This is again just a bit over 20 years ago, and now they're, as with everything that hit the ground running, there's still a lot of misconceptions about central sensitization. So we're really not working in it's a field that is not long, and we're still trying to understand what's really important for us in the clinics.
Yeah, that makes complete sense. And yeah, absolutely. Thank you, Martina, for explaining that. And it's been I hadn't thought of it like that, but you're quite right. Interesting. Thank you. So the science has shifted enormously, as Martina has been alluding to. And for somebody who is hearing this sort of early on their journey, or even for the first time, can you give us a sense of what has actually changed? What do we understand now? What are the sort of key things that we understand now about pain that we maybe didn't before?
So we were really starting to understand in the 80s the peripheral nervous system. Then in the 90s, the central nervous system. Then at the end of the 90s, we had the technology to observe the brain function, like seeing the work of the brain through all sorts of different imaging techniques. Then So that was an interesting part, because suddenly the emphasis was all about the brain processes. And there was a time where pain education was purely about, you just need to understand it, and then your cognitions, it will shift your cognition and emotions, and then it's all good from here. These days, we know that, for a while now, 15 years maybe, we realize it's not just the nervous system, it's also the immune system. And we've got the nervous system being the left hand and the immune system being the right hand of the body. They cannot work without each other. So they're really the two key systems here at play. So these two we need to understand. And they are also interlinked with the stress system. So nowadays, we're actually now talking about a neuroendocrine immune ensemble. So all of those three systems by itself are complex, but put them together and they can create brilliant tunes. And they're very different for every client. But I think looking at the clinics now, it serves us well to acknowledge that pain is much more than what happens in the brain. Pain is also something which happens very much in the body. So we're now back to the body. And this is where I'm actually quite excited. This is where my movement-based therapist has suddenly become much bigger emphasis in the clinical day. Because in the end, I work with the body and understanding what a stress response does in the body, and how can you tune down and regulate your stress response in the body. And maybe when you regulate the stress response, we're also going to change the immune system and the nervous system. So we can now, we're actually in an exciting time. We can, understanding that we went all the way up from the peripheral nervous system into the brain, and now we went back down into the body, honoring concepts such as homeostasis, allows us to work with a bigger toolkit. So we can come from hands-on therapies, working in the tissues, but we can also come from a very CBT, cognitive behavioral therapy type approach. None is exclusive, and no one has to say, particularly chronic pain patients, has to do either this or that. It's a broad toolkit what we can draw on, and evidence like the neuroscience really explains that to us quite nicely.
That's amazing. I think a lot of people watching will be clinicians will be relieved to hear that we're moving back into the body. David Bolton, who is in the audience and a NOI teacher and ambassador, he always said this quote, which I loved, and he said, "The hands are another way of talking to the brain." And I absolutely love that.
And the skin is the biggest sensory organ.
Yeah.
And guess what I did yesterday morning? I went to a PD on musculoskeletal, spinal. What's the update in spinal therapy? And it was so much fun to go back into deep dive musculoskeletal, and hearing also the biopsychosocial model and picking up really little gems about the pathoanatomy. We have to be extremely careful, in particular in my field of persistent pain, that we never ever forget the tissues, and how much good we can do with hands-on in a biopsychosocially informed treatment plan.
I love that. I love that, Martina. Absolutely love it. That is fascinating, and I feel very comforting to hear you talking about the body again in that way, and that they are symbiotic and equally important. I know that a lot of people watching will be thinking, okay, this is great, but what does that actually change? What you've been talking about here, understanding pain science, what does that actually change for people? Just coming back to sort of, the fundamentals of it, the explain pain ethos, learning, methodology. What does this actually change what people do in clinic on Monday morning?
I think it equips you with good clinical reasoning. So you see a client, and he or she comes, they come with a particular symptom complex, and you have to try to make sense out of it. On the one hand, for yourself, otherwise the stress goes through the roof in prior practice if you can't make sense out of what this person is telling you. And also you need to make sense of for the client. And once you don't have to be completely right and have your finger on the pulse straight away, but the from the best case scenario, like you want to understand how can I rationale and reason what I see, and when I understand what I see, I can justify the treatments, or I can start the first trial treatment. And so I think understanding pain science away from every type of treatment form, if it's Mulligan, McKenzie, whatever it is, we go away from the treatment, a particular treatment style, we go into the mechanism. Which mechanism is driving the pain and the symptoms of this client to the best of our knowledge, as much as we can do when we first assess someone. And when we have the mechanisms, I think it's easier to clinically justify the next step, the first treatment. So I think for me, the stronghold of pain education or pain science education is helping us as therapists to really keep a cool head with complex, often very complex problems a client comes in. I mean, if they would all come in with mechanical nociceptive pain, we wouldn't have such a challenge on our hand. But we really want to, we want to be open-minded and also keep cool when someone just drops a whole lot of different systems into your assessment, and you think, okay, where am I starting here?
Okay, that's interesting. So what I'm hearing there is that having these sort of foundational levels of understanding about pain science, it's allowing you to sort of create this relationship, a reassuring relationship with your patient, and create a lot of safety in them, and then you are able to explore a lot of the treatment opportunities together.
Absolutely. And it's validating. So I think validation of the symptoms someone experiences is extremely important. And also, if you can stand solid and say, and because sometimes patients say to me, you think I'm mad, you must be thinking I'm totally mad. And I said, try me. But you just, if you are saying this is complex, but it's not unusual. And let's see if we can find a mechanism that is driving it. And as I said, if I have this ensemble, the neuroendocrine immune, I can explain a lot of symptoms, not just pain, but maybe why they suddenly get more frequently more sick, why they're so lethargic and not motivated, why their speech has changed, their digestion has changed. All of that is happening in the same person and needs validation and explanation. And by that, as you said, we build a therapeutic rapport and hopefully encourage the patient really to take ownership and responsibility as well in their journey.
Absolutely. The thing that strikes me so often is that people come to us and they want to know the pain science. Tell me about pain science. I need this amount of information, and I need to be able to then, how do I then explain it to my patient so that's going to help them? But that is only just a part of what it is that Explain Pain is about. Yes, you need that foundational knowledge, and that is delivered in an Explain Pain course. You need it, or in the books, you can learn that. But a lot of the Explain Pain approach, and this is what I think people often don't appreciate, is it's about the softer skills, which is exactly what you're talking about, which is the listening, the validation, and building rapport, and the way in which you impart that information to the patient. I think there's a statistic, isn't there, something like the patient only needs to know about 10 or 15% of what you know. And if you go too far, then you're actually alienating them. And this is the dance between the two of you, that when people come and spend a couple of days with you on a course or doing the course, they develop that confidence in, actually, I need the pain science, yes, but it's just as important that I've learned how to balance these skills as well.
Exactly.
Yeah.
And it is quite humbling if someone really shares their story with you. And they are often not just complex, they're quite sad stories a lot of times. And that's sort of really looking at the big picture of what this person is experiencing and giving that space to actually allow that to unfold and let them talk is so important, because often we are time poor in our clinics, but can I justify giving this person that space to talk and tell me the whole story that might be a bit beyond than what's happening in their spine right now? But it might be equally important to understand what's the driving mechanism here behind this pain. And I think as movement-based therapists, like physiotherapists, we get into an internal conflict. Like, is that important? Do I want to even hear this? What am I doing with this information? But if you hear the psychosocial stresses and validate them for what they are, and how they will influence the stress system and the muscle system, and why it's not sure that this person can't sleep. And when we all know when we can't sleep, what happens to the pain. So everything is important. And when it comes to understanding pain, everything is important, because everything can be also used as a treatment approach, a way in. So I think we just have to trust that we're not wasting time trying to understand a person, a full person. And I don't remember who said it, but I've got it on whatever slide. But I remember I like that saying that someone said, no one will ever care how much you know until they know how much you care. And I think that's really something which we can build into our pain education. It's not about throwing God knows however many neuroscience nuggets at them. It's about really showing them that you really deeply care to understand them as a person in their whole biopsychosocial and maybe spiritual domain. But you need to come from your own philosophy as it.
Thank you. Oh, I love that. I love the way you put that. It's wonderful. Thank you. So for me, what tends to trip people up then when they first start thinking, all right, okay, I need to understand pain science, and I need to be able to communicate this to my patients. I need to be able to explain this to my patients. Where do people go wrong?
I think, and we've all been there, that we are copycats. We're all copycats. Yeah? And so when I might hear someone with authority, like David Butler, he created beautiful one-liners, which I have a trouble, by the way, translating into German. But don't get me started on the translations of the Sims. But motion is lauschen. Things like this are super little metaphors and mantras for patients to give. But I think what trips people up sometimes is that they deliver these slogans without enough explanation what it is. And it's a fine line. While it is really good for clients in the end to have these mantras, if we throw them too quickly, too early, they might not feel taken serious. And that is cultural as well. We know, teaching and working with German therapists and working with Australians, I know I've got a bit more larrikinism potentially here in Australia than in Germany. There's culture as well. There's being careful about one-liners that are totally right, because they're standing they're just the peak of the iceberg, and they're absolutely right to say, but just being careful, because they're often the ones I remember when I just learn pain science education, and I throw them if I throw them in too early, I might lose my patient. I think that's one. Can you
think of an example, Martina? I'm sorry to interrupt. Have you got an example of one of those
Well, the classic one is your pain is in your brain.
Yeah.
Which is absolutely true, but we could maybe say you need a consciousness to experience pain, and we have worked our way from the peripheral nervous system through the spinal cord into the brain and back down again. But so the brain is there and has an opinion, and mind matters. But just sort of, it's really what people often come into particularly in the pain management group, it's one of the things, because by the time they get to us, they've been seen by quite a few people, and something they come across quite often, and it very seldom lands. Part of them understands what people are trying to say, but there's always this doubt, they don't take me serious. Meaning I
Yeah,
should
that's
just
the classic one, isn't it? Are you telling me this is all in my head? And in fact, in the clinical discussion on the YouTube channel, you will find at least one other session where we dive really in depth into that one sentence with one of the teachers, and they talk you through how to work through that. And I think the thing that strikes me, Martina, is that we're doing an introduction today, and there's so we could have drilled down on so many different elements of what we've talked about and given hundreds of examples. But obviously we haven't got time for that today, and that's where people want to do deep dive with you in a course. We have got one question here, which I think is worth taking, and it's from Judith. Thank you. It's a great question. And she said, could you give me some examples of the driving mechanism behind the pain?
Well, we know that pain at any point in time, it doesn't matter if it's an acute state or in the chronic state, is a protective mechanism. The question is, what is it protecting about? Like, is it just the acute are you protecting the acute wound in the acute phase, or are you protecting from total overload? Like someone whose homeostasis, the balance between stresses and resources is completely out of kilter, and this is not going to end well if they keep going, having that amount of load on them and too little resources. So here we can argue that even in the subacute chronic state, pain is a protector because it asks people to re-examine, what am I doing? Like, is that sustainable? Is this actually my best interest? So again, that might not be my opening question to a client or I choose when I want to bring this in. But to answer Judith's question, that would be one thing where the pain as a protective driver is really important. Stress as a protective driver, muscle guarding as a protection. Yeah. But what for? I mean, in terms of muscles, going back to my new favorite topic of musculoskeletal medicine, we know that muscles who are not playing nicely together, where we have muscle coordination issues, or muscles who are weak, often protect themselves with pain till they get trained up. And just sort of, what's the drop? Yeah, I hope that answers some of it.
Yes, it does. Thank you, Martina. And again, in the YouTube channel, you will find a whole session on this exact question, so you can take a deeper dive in there if you're interested. Now, thank you, Martina. That was absolutely fascinating. Just at the end, I'm going to ask you to give us a key takeaway from what we've talked about today. But in the interim, just before we start to wrap up, so we've just had a small taste today of sort of things that you should be thinking about when you're moving into this world of pain science and pain science education. And anybody that's been inspired by what Martina has said today, and somebody has just said that it's a really reassuring discussion to have, and I would agree with that completely, that we're going back to the body and not everything is in your brain, which I think really sort of freaked everybody out, clinicians and patients alike. So it is really reassuring, and thank you for that, Martina. So Martina has some courses coming up. She has an online course coming up in German, and also a couple of in-person courses in German too. So could you just tell us a little bit more about what somebody would expect to come away with after having spent 2 days or the equivalent of 2 days with you on an explainpain course?
Given the fact that I'm teaching in Germany and I'm allowed in Germany to deep dive very much into the physiology. Like we teach culturally sensitive. So in Australia, I teach slightly different than in Germany, but in the German courses, we really deep dive into the physiology of peripheral nervous system, central nervous system, modulating systems, brain networks, and then the immune system, the endocrine, so the NEI ensemble. We also bring in, and this is where the exciting new research is, predictive processing. Another one. And then also, as I said, for me, throughout those courses, it's really important that to reassure participants that they come with a lot of knowledge and they come with a lot of different treatment avenue and treatment strategies. It's just a matter, how do I justify and how do I justify to myself that I'm doing this treatment now, but I'm also, how do I explain it to my patient why? Maybe, yes, I come to a movement-based therapist, but maybe we're doing breathing technique, we're doing relaxation techniques. We have a chat about what kind of enjoyable activities they should schedule into their week. Because I might run into conflicts of expectations from someone who comes to a physiotherapist. But as I said, particularly with the complex pain patients, we are allowed to branch into the biopsychosocial model to treat pain.
Thank you. That's wonderful. I've really enjoyed this conversation this morning. I think it was a lovely way to start the week. And I think from what we've seen in the chat and the Q&A that everybody's really enjoyed this. It felt very accessible to me, this did. Felt like less intimidating than some of the like heavy stuff that we do. So Stuart's just said, will you be doing any courses in English? No pressure. We may do.
Exactly. Joanna, we talk.
But Stuart,
ask Joanna.
Yeah, I mean, that is something we could consider most definitely. But because Martina's in Australia, it's more difficult with the timings to do the European courses with her. But you will find on the website, we've got some amazing European teachers that are teaching these courses in English. So Stuart, just jump on there. There's one with Ben Davies coming up at the end of March, online again, so completely accessible, fully recorded. So all our teachers are amazing. But Martina, thank you so much. And thank you for such an interesting start to the week. And thank you everybody for joining us live and for your questions. We absolutely love connecting with our audience in real life, almost on as in real life as we can. And do check out the Clinical Discussion YouTube channel. Share it with your colleagues, like it, subscribe to it, and you will then be notified when we upload any new videos. So thank you, Martina.
Thank you
to our audience for joining live. I hope you enjoy the rest of your day and evening and week. Take care, everyone.